questions. Case 1. A repaired cornea and a large written intraocular foreign body just beyond the posterior exit wound, trapped in the sclera at the inferior macula. Oh my God, a daunting task was ahead of me. Vitrectomy was performed. An attempt to release one pole of the trapped foreign body with a bent 24 gauge needle tip failed. The foreign body went vertical, then aligned itself horizontally and got trapped in the sclera. Use of 20 gauge foreign body holding forceps and magnet after converting one port to 20 gauge also failed. Now what else is left? Then came the lightning flash to the surgeon. Radial releasing incisions in sclera. Multiple radial releasing scleral necks were made using 23 gauge MVR blade.
It was almost an impossible kind of situation for me to took out the partially exposed RIOFB.
The retained intraocular foreign body was bimanually manipulated with bent tip 24 gauge needle and magnet and made intravitreal. It was then removed through the limbal section. PFCL removed, laser done around the break after a complete fluid air exchange, and silicone oil injected. Post-operatively, retina was on. 5 months later, final visual outcome of the patient was
After silicone removal and glued oil implantation, patient finally gained 6/9 vision. Thank you. So this was my first complication, first longest day. My second longest day is what Dr. Souvik showed, that sudden intraoperative casing choroidals that arise from during my routine VR surgery. It was a case of retinal detachment with choroidal detachment and with a lot of hypotony. So I have injected just before injection, just before surgery, I have injected BSS intravitreally to raise the IOP and checked all the infusion port and all the other ports, whether it is intravitreal or not, and then started the surgery, did vitrectomy, and there was a tear in the infratemporal quadrant, and injected PFCL and did vitreous base excision, everything, all the routine procedures, and finally at the end of surgery I was doing the fluid exchange and did laser, and the only thing left for me, it was just to inject the silicone oil. I was waiting for that. I just removed all the instrument and asked the assistant to give me the VFC syringe and just see. Nothing is visible. When I went inside, nothing is visible. Now you just see the absolutely kissing choroidals retrolental. And then what next? What should I do? Basically, I was not very much perplexed state of mind, because it was a unique complication happened to my. And I saw that infusion was in partial fluid exchange state and it was partially withdrawn, so I removed it. I was pretty sure that my supratemporal quadrants and supranasal quadrant was is totally absolutely okay inside the vitreous cavity. Just see if I repeat the situation like this, I can see the choroidals just vanished, just vanished even just after introduction of this infusion port in air fluid exchange state. Then I introduced my trocar cannula inside the suprachoroidal space. I was thinking that it might be the suprachoroidal air entry, and just removed all the air after raising the IOP, and then introduced my routine trocar blade from another side. 40 minutes away from the limbus and check the infusion port. It is inside the vitreous cavity. Then rest of the fluid has been removed and injected silicone oil. So I was fortunate enough to get rid of this kind of devastating nightmare. Thank you. And my third complication, it was a very unique situation. Although the final outcome was not gone well, it was a repair. It was a like post firecracker injury, and a lot of hyphema was there. Primary anterior segment surgeon removed the hyphema first. Then I did lensectomy from the anterior approach. Then gone inside to remove all the residual lens matter and the vitreous exudate. It was quite dense, and I was not getting any plane to separate all the exudates from the surrounding retina, and you can see just some unusual particles are coming out, and it was a case of firecracker injury, and I was thinking about the sulfur granules or the iron particles, all these things, but the foreign bodies were not like that. I had a question, what could be the foreign body, nature of the foreign, because we have not sent it for the identification purpose. Like you can see the granules, it's just like mercury foreign body, but it's not mercury. I've gone through the literature that firecracker injury, mercury foreign body is not there. It's mostly there sulfur granules and aluminum particles and sodium and other copper also, but mercury particles are not there. My presumptive diagnosis might be their aluminum particles, so I just tried to remove the exudate from the underlying detached retina. It was already retina detachment was there preoperatively, and finally I removed the exudate as much as possible. It's not totally 100% gone, but still. And but the particles, the glistening particles were quite abundant, especially in the inferior half. And you can see the particles were quite studded overlying the retina as well as the within the exudate itself. You can see the silvery colored glistening particles. So my assumption, they are intraocular aluminum foreign body. They can cause very purulent kind of inflammation. Hardly we can, and preoperatively also aluminum is hardly you can see, because the bone density index of the aluminum is very low. You cannot separate the particles from the bones. So, and intraocular, just see the eyelash, I have removed it. Very bad kind of situation, and finally I could able to settle the retina and injected silicone oil. Patient's vision was PR inaccurate, preoperatively and postoperatively also. He couldn't save the eye. So because of this purulent fulminant inflammation, it is very difficult to save those eyes. Otherwise, you have to remove the, you have to eviscerate this kind of eyes. So another thing, like if time permits, that basically in submacular hemorrhage, it's very you should be very cautious to avoid the intraocular. During surgery, you have to remove the, you have to be cautious regarding your intraoperative macular hole formation. In my initial stage, during the injection of subretinal TPA and AR injection, in one of my cases that I wrongly injected the subretinal TPA inside the macula, not outside the macula, and just see there is sudden egress of fluid coming out from the macula fovea, because the fovea is the thinnest part of the macula, and easily foveal blowout can occur during the surgeries. I just did a little bit of drying to dry that iatrogenic macular formation, and did fluid exchange, SFC's gas injection, advised the patient to do strict prone positioning, and postoperatively I was fortunate enough that macula was actually closed, and patient vision finally improved to 6/18 vision. But I was fortunate in this case, but not always you are fortunate enough, because in my another case of old submacular hemorrhage, when I injected retinal TPA, and finally I ended up like with postoperative macular formation. Now I have to reoperate the patient again. So what is the procedure should I do? So I plan for some kind of minimalistic approach, because less you do, less complication you will create. That is my philosophy. More you do, more complication you can face. So I just strain the ILM and try to do the inverted flap technique, but not all around the macular hole. Just I peeled one flap from the temporal side, just like Dr. Zofia ideally. Initially, he proposed that from the temporal side, just opposite the flap over the macular hole. That's all. And nowadays, we all do the ILM pinning around the macular hole. But in this case, I just peeled the ILM from the macular hole side. Then started doing fluid exchange again. I was not pretty sure that whether macular hole should close or not, but my gut feelings was saying macular hole should be closed, and finally it closed. So these are the things, the intraoperative complication or something unusual. So my question to the audience as well as our esteemed co-speakers, what could be that foreign body in my third case? Is it aluminium foreign body or something else? What is your opinion? Ha. Ha.
Basically, I think it's a gunpowder that has gone inside a non-essential.
They come in so many different forms and shapes.
And it contains all kinds of dust and also.
Had to be sent to the lab.
Yes. That was gone with the cutter, not with the forceps. So, I have to filtrate it from the cassette fluid. That was the.
Dr. Subhendu, the first
Yes.
case that you did a large foreign body,
Yes.
you could also try to remove it from the outside, see outside conjunctiva and send whether it is more easier to remove
Yeah,
it from
basically
outside.
there was a lot of vitreous hemorrhage, so I couldn't think if it is gone from the outside. That means the part of the foreign body was inside the vitreous cavity. It was exposed, and most of the part it is outside the foreign body,
Yeah, yeah.
and outside the. But
Outside.
in the CT scan, it was showing that it is inside the ocular coat, or in ultrasonography, it is within the vitreous cavity. But it might be due to the clot in the ultrasonography, or maybe it is the foreign body, which is very difficult.
Quite
It's quite
posterior.
posterior,
So if
quite
we had-
posterior. So if you can do such a posterior placed magnetic, yes.
I mean, if you bridle all the
I-
sutures and try to see,
I tried with the magnet, but it failed because it's just strapped. It's gone inside, then horizontally, then gone vertically. So it's very difficult to. Yes.
I think you'll change your mind once you look from outside. It's easier to remove it from outside. If you
Yes.
Have a look.
But it was such a posteriorly
Bridle all the
placed.
sutures and then see outside. And
You
it's
could have
easier.
injured the optic nerve. All these complications. So
The
thank
next
you,
session, people
thanks
waiting
to
here.
all the audience for attending our session. Hope next year we'll come with newer complications. Thank you. Long live retina surgery. It should not be robotic. We should not leave our retina surgery into the robots, hands of the robots.